perfect. Okay, so over there, every single group has been like a little like strayed, you know, when you get into the room. So that's why we have ATLS, Advanced Trauma Life Support, and that's why we have the ABCs, right? It's very critical that you just stick to that algorithm because it doesn't let your mind get clouded and it doesn't let you miss anything that's going to kill the patient, okay? So, to reiterate, where do we start?
Airway.
A, okay, airway. So how do I know if the patient's airway is patent?
You look into their mouth and see if there's anything occluding it?
Yeah, you can look in, but what's even easier than that?
If they're breathing, talking?
Exactly. So this patient comes in, they're alert, and they're talking to you. Airway's good, okay? What if the patient is unconscious or has stridor or blood in their airway, then what?
Then you should intubate.
Yeah, we need a definitive airway, right? So we're going to intubate the patient. So what is our definitive airway? Well, the first step is an orotracheal, endotracheal intubation, right? Okay. So if you can't proceed with this, maybe there's maxillofacial trauma or something going on that's obstructing the airway, what is our next approach?
Crike?
Yes, a cricothyroidotomy, okay? So cric. So that is a, quote, surgical airway, okay? Then, how do I determine whether this is in the right spot? There's one answer to the question. It's a test question. What is it?
The lungs are rising. End-tidal CO2?
End-tidal CO2 waveform capnography. You're going to do all the other stuff. You're going to listen to breath sounds. You're going to look for chest rise. You're going to get a chest x-ray. However, waveform capnography, end-tidal CO2 is the answer. Okay, what's next?
Breathing.
Okay, so you listen to breath sounds. You hear absent breath sounds on the right side, and the patient's trachea is deviated away. What are we suspecting? Yeah, and even more specifically, because of the tracheal deviation, could be a tension pneumothorax. A tension pneumothorax is what type of shock state?
Obstructive?
It's obstructive shock. Good job. So what are two other examples for the classic 3 for obstructive shock? Tension, PE, massive pulmonary embolism, saddle pulmonary embolism, and cardiac tamponade, okay? So all 3 of those are impeding the venous return and the blood flow back to the heart, okay? How do I fix the tension or the pneumothorax?
Needle decompression?
So in the field or somewhere I don't have it, I could do a needle decompression, and then in the trauma bay, I would put a chest tube or thoracostomy tube, okay? And where is that placed? Yeah, 4th or 5th intercostal space. Mid-axillary line, always stay higher than you think, okay? Because you don't want to end up in the abdomen. All right. C, this is the biggest issue for our patient that we had next door. What am I looking at?
Circulation.
Yep.
Vitals.
Exactly. So the vital signs are the most important thing here. What is the heart rate? What is the blood pressure? And we're going to talk about the different classes or stages of hemorrhagic shock in a second here, okay? So what do I do for my intervention?
Fluids, 2 large bores, IVs.
Yeah, so we need to first place 2 large bore peripheral IVs. And then if we took it a step further, because we're really in a bad spot, we could put a central venous catheter. What are the 3 places where those go? Subclavian, IJ, internal jugular, femoral. Good. In a crashing situation, we usually go for the groin line, okay? So, and then what are we doing here? We're giving first, you said, maybe some warm crystalloid. If that's not working or we suspect the patient is truly bleeding, we proceed with?
PRBCs, platelets, plasma.
Exactly. This is a massive then transfusion protocol in a 1-to-1-to-1 fashion of, like you just described, packed red blood cells, PRBCs to FFP to platelets, right? Excellent. All right, D is disability. What is the quick and dirty way to assess for a brain injury? And then what is the quick and dirty way to assess for a spinal cord injury?
Pupils.
Excellent. So pupils for the brain. And the spine?
Maybe pain or sensation.
Motor.
Extremities.
Can they move all of their extremities? Okay. If they have a high spinal cord injury, they're quadriplegic, they're not moving anything, right? So very simple, quick and dirty. Brain, uncal herniation, cranial nerve 3 compression, blown pupil, okay? Midline shift, uncal herniation, extremities, self-explanatory. And then we take that a step further because we talk about the GCS, the Glasgow coma score. So we're going to talk about that in a breakaway as well here in a second. And then E is?
Exposure.
Yeah, and what did you see in our friend next door?
Seatbelt sign.
Yeah, so she had a seatbelt sign. So that's going to be high suspicion of intra-abdominal trauma, maybe a bowel injury, maybe a solid organ injury, okay? So let's break this out now and talk about the GCS. So what are the 3 components to the GCS?
Pupils.
Okay, not pupils, we call it,
Responsiveness.
we say eyes, right? So eyes are 1. Verbal is the other.
Pain.
Nope, there you go, motor, okay? So of these 3, which one is the most important prognostic indicator for how a patient is going to do?
Eyes.
Motor.
Motor, okay? Which one's worth the most? Motor, okay? 6, 5, 4, okay? So what's the most I can get for being normal, walkie-talkie? Yeah, 15. And what's the worst? 3. Okay, so let's start with eyes. To have a 4, what do I need to do?
Pupils are equal.
It's not about the pupils. Their eyes are open spontaneously. Okay, so it's like me and you. Our eyes are open spontaneously. If your eyes are closed and I say, hey, open your eyes, you opened them to what type of stimuli? Verbal, to verbal stimuli. So if you open your eyes to verbal stimuli, you get a 3. Hey, open your eyes. They don't open their eyes. Hey, open your eyes. Painful stimuli. So you sternal rub them and they open their eyes, okay? And then the last one, obviously, their eyes aren't open. Verbal. What's the best I can do? They're alert and oriented times 3, right? They're totally there. What is then next for 4, which is, in my opinion, the most common trauma patient that we see? They're confused, right? So this patient's confused, they're concussed, so they get a 14 overall. A lot of our trauma patients come in a concussed, confused, altered state, okay? If they're not confused, what's a 3? It's even worse. So they're making words, but they just don't make sense at all. But you're still saying like words, okay? What about a 2? If it's not words, what is it?
Sound.
Incomprehensible sounds. So moans, groans, whatever, okay? And then 1, obviously, again, nothing, okay? Motor, most important, especially for predicting an outcome in a trauma patient. Why is that? Well, what's a 6? I tell you, hey, squeeze my hand. So you did what? And you do it. Yes, you follow commands, okay? So that's a 6. If I induce pain over here and you swat me away, what's that called?
Localizing pain.
Yes, you localize pain. If I do the same thing, but instead of localizing the pain, you
Move away.
withdraw. Yep, perfect. You withdraw, you get a 4, okay? Now is the important thing because of the outcome, right? So then someone comes in with a motor 3 or a 2, they're in trouble. Why is that?
Isn't it with like decerebrate or decorticate posture?
Exactly. So now they're, quote, posturing. So this person's in a bad spot, right? So decorticate, you grabbed your core, so it's flexion of the upper extremities, okay? So that's where a 3, decorticate. And then what's the other one? Decerebrate is when there's extension of the upper extremities, which is even worse, okay? So decerebrate and then nothing, okay? Make sense? All right, so then let's talk about the different classes or stages of hemorrhagic shock. because that's what happened to our patient next door, right? So she came in and she had a heart rate of 106. So by definition, which class of shock is that patient in right when they walked in the door?
1.
2.
2. Why is that?
I believe it's in 1. It's kind of normal. The only thing that's elevated is just lactate.
2 is tachy.
Exactly. So how many liters of blood are in a normal 70-kilo human?
5.
All right, so 5 liters of blood. So we're going to talk into percentages of blood loss in volume. We're going to talk about heart rate, and we're going to talk about blood pressure, because these are the important concepts here. So class 1 is less than 15% or 750 cc's of blood loss. What happens to the heart rate and the blood pressure in class 1 shock or hemorrhage? Nothing. What is the one vital sign that can change? What is that? A narrowed pulse pressure, meaning your systolic pressure is here, your diastolic pressure increased due to the release of catecholamines in the sympathetic response to your shock state, okay? However, the heart rate and blood pressure didn't necessarily actually change. So that's why this is considered compensatory shock, okay? So then if we lose 15 to 30% of our blood volume, or 750 cc's to 1.5 liters, okay, that's the first time we see tachycardia, okay? Then if we lose 30 to 40% or 1.5 to 2 liters, okay, what is the vital sign 1 there? Yes, that's the first time when we theoretically see hypotension. Important, important, okay? And then here, greater than 40 and greater than 2 liters, almost half your blood volume, okay? So she progressed through here, right? And then something happened in there. So she came in tachy, she got hypotensive, and then what happened to her? Yes, she coded. She lost pulses, right? So anytime a patient loses pulses, there's 2 algorithms here, okay? Which is this side versus this side? Shockable are what? Pulseless VFib, pulseless VTAC. These are typically cardiac in origin, right, of the issue. So it's typically like an MI that drove this. Our patient went into what? And what's the other one over here?
Pulseless electrical activity.
PEA, pulseless electrical activity. Excellent. And this is easy to remember because it stands for push epi always. All you could do is give epi and try to fix the problem. Over here, you defibrillate, you give more medications, and you're trying to work them up from that standpoint. So in trauma, there's 2 types of mechanisms. There's blunt and penetrating, okay? So if this trauma patient loses pulses, there's a thing that we can do as trauma surgeons to try to mitigate that. And what is that called?
You clamp the aorta.
Exactly. So you clamp the aorta. How do you accomplish that? What surgical procedure? A left anterior lateral thoracotomy. Okay? All right. Now we have access to the chest. We can do intrathoracic cardiac massage, and we can cross-clamp the aorta, okay? Thus delivering blood to the coronaries and to the brain and trying to regain pulses, okay? If I have the same patient like next door, and she comes in not looking so great, and I think she's bleeding, I can also do something fancy nowadays, which is this. Anybody know what this is? So the R, what do you think the R stands for? We've been talking about it. Resuscitative. E is inside the vessel. Endovascular. B is I put this special little thing in here with this on it. balloon. O is I stopped blood supply. Occlusion of the aorta. Resuscitative endovascular balloon occlusion of the aorta. So if I have a hemodynamically not looking so great patient, it's nice if I put a femoral arterial line because I can simply upsize it to a 7 French sheath and deliver the Reboa catheter if the patient were to lose pulses. If they come in pulseless, it's very hard to get that access because there's nothing there, right? So that's when we typically have to just go straight to a thoracotomy. All right, so then this is considered zone 1, okay? And then right above the iliacs is considered zone 3, and then everything else here is considered zone 2. Zone 2 is like we don't want to deploy the balloon there because you have your what? This, and these. What is the top one? Celiac, middle,
SMA.
bottom, and renals. Exactly. So we want to just stay away from there. So zone 1 is the equivalent of us cross-clamping the aorta in the chest. Zone 3 is great for pelvic and obstetric trauma. Okay? Make sense? All right, excellent. Good. You can shut that.